Almost everyone knows someone whose kids had to deal with seizures. Most of us know that diagnosing seizures in kids is very hard.
If you miss that, it means you miss the child. But if the proper diagnosis is made, we can save the child, and we can, in many cases, child can have a normal life. So then the very first thing to do, please do not panic. Keep your nerves intact because your child is in difficulty. Many patients, even today, we saw one of the patients who had like non-epileptic stress-induced seizures, and we asked, "Why are you so stressed?" And he said, "Oh, she cannot go to gym because of the fear of ice." Actually, I give a very high value to the observation of the parents and observation of the teachers. So we, as a doctor, we may know about the diseases well, but you know your child. You really do not need to bound the person. And please do not put anything in their mouth because that can be dangerous during the seizure. No need to put your finger because they can bite and you can get really. So here's the question. The question is that can a normal brain have a seizure? Answer is yes. A normal brain can have a seizure in situations of, for example, fever, in situations of electrolyte imbalance. Seizure itself is it's just like a fever. It is just a response of a brain that there is something wrong with me. And that a brain actually registers its complaint in the form of a protest, which appears in the form of a seizure. I would just say one thing. Please do not give up on your child. So there is a lot of advancement, especially last 10 years were amazing. And I have like even in my practice, there are living examples when there are certain parents, and I really admire them because and they did not give up on child. And now their child is are there. There were times when they were having 200 seizures per day.
Wow.
To a time now they are honor students and they're living a normal life.
Hello and welcome everyone to our very special episode of the Homeostasis Podcast. We have Dr. Naeem Mahfooz with us again. You probably listened to our earlier podcast, and if you haven't, go back and listen to it. Dr. Naeem Mahfooz talked about pediatric brain development, what's going on in kids' brain when they're growing up, what are the things that can positively or negatively affect the kid's brain in the growing age. Dr. Naeem Mahfooz, a very good friend of mine. He is Associate Professor of Neurology at University of Toledo, Ohio. He specializes in neurology as well as pediatric epilepsy, and he also specialized in EEG and electrophysiology from the world renowned Cleveland Clinic, Ohio. So he has once again agreed to give our audience some more of his valuable time. And today our topic is not a very common problem, but a very important problem that parents of the kids in the growing age do not want to miss. Almost everyone knows someone whose kids had to deal with seizures. Most of us know that diagnosing seizures in kids is very hard. They're not typical tonic clonic seizure that we are used to seeing in the adults. They can come in different shapes and forms. And today we are going to ask Dr. Naeem Mahfooz to educate us on how to recognize seizures in kids. One of my very close friends recognized a seizure, a very subtle seizure, when her kid was on a swing and was just looking at a distance in a weird way, and eventually, that small pick led to the diagnosis of a brain tumor, which was taken out when that baby was 2. And alhamdulillah, that kid is now 5 years old, perfectly fine, living a very healthy life, neurologically perfectly normal. So, knowing these things can really impact the quality of life of your kids and give them a chance to a normal and healthy life. So, thank you very much, Dr. Naeem Mahfooz, for joining us once again today.
Thank you for having me, Ahmed.
All right. You just told me before we logged in that you're in Minneapolis. So is it still tons of snow there and you're still shoveling your backyards? I know you live in Toledo, but you also go and help people in Minneapolis dealing with neurology in kids. How's the weather there? How's the environment, and how's the social weather there these days?
Weather, temperature wise, it's not very different from Toledo where I live, but socially, it's quite tense here. Like people are not going out in the streets because of the fear of ice. And I'm working in one of the hospitals in Minneapolis, and many patients, even today, we saw one of the patients who had like non-epileptic stress-induced seizures, and we asked, "Why are you so stressed?" And he said, "Oh, she cannot go to gym because of the fear of ice." And
Wow.
even today, I just did an admission concerning because parents think that they cannot go to clinic, and if they have somehow reached to emergency department, so they have to take care while they are in
Yeah.
ER.
Yeah. Well, I hope the situation gets better soon before we lose any further lives.
Mm.
And I hope everyone in Minneapolis is safe. So we'll quickly jump into our topic. I know your time is valuable. You're on call and you're still getting pages from your hospitals. Let's discuss the first question that I just kind of alluded to in the introduction. What do seizures look like in kids, and how are they different from adult seizures?
And a very important question. So kids, the way seizures are presented in them, like they're quite different. So we have to basically categorize kids based on their age. So when they are very little, when they are neonates, at that time the seizures manifest in the form of like subtle change in facial expression. Then they will have dilatation. They may start something what we call bicycling movements, in which they will act as if they are moving a bicycle from their hands and they are doing bicycling movements of the legs. The other time, what happens? They face get pulled away on one side, or they get generalized tonic-clonic seizure, which everybody is aware of. And then when they grow a little bit older, there are some special type of seizures which you see in pediatric population, which you don't see in adult. One of them is called absence seizure, and it is a seizure in which kids they will get a behavior arrest in the middle of a conversation and or in the middle of an activity, and then when they start staring into the space, they do rapid eye blinking, they start lip smacking, do hand fumbling, and then they immediately get back to themselves whatever they were doing, and they will not have any recollection of what happened during that time. And then there are seizures in which there is just eyelid fluttering, very quick, as if somebody is giving an attitude. And
Mhm.
then there are certain seizures which are very dangerous in kids, especially at 6 months of age, 6 to 9 months of age. That's when they are normally seen. And they are called infantile spasms. So these are the seizures in which all of a sudden kids get like this certain flexion of their limbs and the body would
Mhm.
move forward. So it has variation. Sometimes it can move forward, sometimes the body can move backward. And very often general pediatrician and other doctors, they confuse it with gastroesophageal reflux. But it's a neurological emergency. If you miss that, it means you miss the child. But if the proper diagnosis is made, we can save the child, and we can, in many cases, child can have a normal life. And then one of the thing which is very different in pediatrics versus adult, there is something called drop attacks. So they are standing and then all of a sudden they fall to the ground.
Mhm.
That thing normally do not be seen in adult population, but this is very particularly in pediatric population. And also in many of the pediatric syndromes, this is also one of the common features.
Well, thanks for explaining that. So, just to put them in different categories for simplification, you mentioned the tonic-clonic seizures, which we are used to seeing as adults, where the whole body is shaking, the person is frothing at the mouth, and it may last a minute, it may last a couple of minutes. What are the different seizure types in kids? Especially tell us about the ones that parents should be aware of that they can't afford to miss, and the ones that you usually see easily missed in your practice.
So many a times parents think that the child is doing something just which is like a behavioral phenomena.
Mhm.
Like I give an example that if a child starts doing an activity in which there is a certain like head drop, or child does an activity in which he just get freeze all of a sudden, or child do something like there is a like a sudden flexion of the body, or there is a like a subtle movement of one part of the limb, which could be just simple hand movement, like this kind of movement, or there could be the movement of one of the legs, but it's like a rhythmic movement. Or you notice that the child is like talking, and then all of a sudden it just zones out and it acts as if the child is frozen. Or you notice your child is kind of walking, but in the middle of walk he become clumsy and he falls to the ground. And then, for example, he there are some kids when they feed, so they are feeding normal, then all of a sudden they just spill everything on them. So the most important thing for parents is like to observe the pattern in it. If something happens once in a blue moon, that's different, you can ignore it. But if there is a consistency, like there is stereotypy, which means these episodes are happening again and again, then they should pay attention to it.
And how many times would you ignore something like this before you start taking it seriously? Because any kid can spill something once in a while, or they lose focus and they start daydreaming. How do you differentiate daydreaming and tics from actual seizures?
Actually, I give a very high value to the observation of the parents and
Mm.
observation of the teachers. So we, as a doctor, we may know about the diseases well, but you know your child. If
Yeah.
you notice that your child has started something which you have never seen before, and there is no any specific pattern to it. For example, the tics are like kind of a quick body movements, which could be just like the eye blinking, or they would create a very specific kind of sound, which could be like throat clearing or the nasal sniffing. And normally these like tics normally happen in a situation of stress. But
Mm.
seizures are something which they just happen all the times, or they would happen, for example, first thing in the morning. Upon awakening, they will just start doing this activity, and they may not normally you see during stress. But one thing which normally like the seizures are seen more frequently during sports activity and during hyperventilation, when they are
Mm.
like in any situation when they are breathing faster, so seizures tend to happen more.
I see. Can you tell us a little bit about febrile seizures? And when do you say, okay, you can just attribute the seizure to the infection that the kid had, some kind of ear infection or high fever? And when do you need to take it more seriously and go see a neurologist and, ask for further workup to make sure it's not something that's going to affect you long term?
So like febrile seizures are the seizures in which whenever there is a sudden increase in the body temperature, we know that your our hypothalamus in the brain is kind of a thermostat. So whenever you are infected with a virus, the virus or the toxins which are released as a result of the infection, so those toxins they increase the thermostat setting. So
Mm.
when that thermostat setting is increased, our body reacts and the temperature of the body starts going up. During the time when the temperature is going up, our the brain reacts, and then the brain starts seizing. Now the question is that can normal brain seize with high temperature? Yes. Every one of us, if the temperature of the body is high enough, the brain is going to seize. But there are certain some people in which even the little bit increase of temperature bring the seizure to them. So many a times there are genes involved because, for example, they have the sodium channels, which
Mm.
are a little bit unstable compared to the regular population. So they can cause seizures, or there are some other genes like, for example, the potassium channel, the calcium channels. They may also have a role in it. But there is something to understand about the febrile seizure. If you have a normal person who gets the seizure, so that seizure typically will be a generalized seizure because
Mm.
every single cell in the brain will respond to it, will respond to the temperature, and you will have a generalized tonic-clonic seizure. And that seizure will normally last just for a few seconds or for a minute or 2 minutes, and then it will stop, and it will be only one seizure.
Mm.
But if we see a pattern in which a person gets a seizure, so this very specific type pattern we classify as simple febrile seizure,
Mm.
and that kind of like febrile seizure usually does not affect your brain development, your cognitive abilities, or it does not pose much risk to you. But If a person gets a seizure, but and get a generalized seizure, and if there is a situation and the seizure does not stop,
Mm,
and the patient goes into like a seizure for more than 15 minutes, and what we call status epilepticus, which means that you are in a
mm,
seizure and it just like not stopping at all. So that's not a normal thing.
mm,
Or you get one seizure, and after one seizure you keep on having seizure after seizure. So that is also not a normal thing. Or a
mm,
certain situation when you get a temperature, high temperature, but instead the seizure is only coming from a very specific part of the brain. For
mm,
example, the patient start, the eyes are moved to one side, or there is a stiffness of one side of the body, or only
mm,
one side of the body is twitching. So that we call a focal seizure. So all these scenarios, when the seizure is very long, or multiple seizures are occurring, or the seizure which is focal in nature, so that we call complex febrile seizures. And those are the seizures we do. Those seizures need thorough investigation because we need to
mm.
find out if there is something wrong in the brain.
Oh, that was very helpful. Is there an age cutoff for febrile seizures, like 6 years, 12 years, 15 years, after which, if you're having a seizure during an episode of fever, it cannot be a febrile seizure and it has to be worked up? Or
Like
there's no age cutoff where it's across this all spectrum of ages?
there is an age cutoff. Like
Mm,
I even did a research on this topic, and
mhm.
what I analyzed a lot of data, and what I figured out, 6 year is the cutoff.
Oh, really?
If you are having a seizure with fever, and even after 6 year of age, that's not a normal thing. So
Mm,
if normally they don't happen after 5 years, there may be like few cases outliers, but they will be like maybe like less than 1% among the whole population of febrile seizures.
I
So I
see.
take it pretty serious.
So if someone is having a seizure after an age of 6, even if it's during an episode of fever, it needs to be looked into.
Correct.
So, talking about the emergency measures, and then we will discuss epilepsy and different factors that increase the risk of epilepsy. But talking about emergency measures at the time of seizure, what can the parents do when they see their kid having a seizure? I mean, the first time it's a very panicky situation, but what would you suggest to someone who is watching their kid having a seizure right in front of them? What should they do, and what are some of the emergency measures they should take as soon as possible?
Okay, so then the very first thing to do, please do not panic.
Mm,
Keep your nerves intact because your child is in difficulty. He's in a very chaotic situation, but you need to keep yourself intact. Call for help because two people are better than one person, and then you reach out to the patient or your child who is seizing. So the first thing you do, move them to the left side of the body.
mm,
So right is also okay, but left is better because the chances of aspirations are less. And then you remove anything around them which they can hit and they can get injured. Just clear the area.
mm,
And then after that, if you have, then you look at the time so that you know like how long it would last. And then you really do not need to bound the person. And please do not put anything in their mouth because
mm,
that can be dangerous during the seizure. No need to put your finger because they can bite and you can get really hurt. And then if during the seizure you know that there is a change in face color or any difficulty breathing, in that situation, just put your finger at the angle of the mouth, and then you do chin lift and jaw thrust. That
mm,
open the airway and the child can breathe better. And then after that, if you have somebody, after making sure the child is safe, if somebody can make a video, that can be very helpful for us. And if this you are seeing this for the first time, I would say just call 911 or the rescue 1122, whatever emergency service you have, so that you can get appropriate help. And if you have seen this situation before and you have the emergency medicine, then usually 3 minutes into the seizure, we recommend giving emergency rescue medication. The emergency rescue medication, there it is available in multiple forms. It's available in the form of a oral wafers, which
mm,
you can put into the cheek, and
mm,
it can get absorbed, and or the child can swallow a little bit. Or there is approach of giving rescue medication into the nose, It comes in like of an intranasal spray you can put into the nose and then you can spray. Or there is also a method of giving rescue medication per rectal. But that is for little babies, it's okay. But nowadays, we don't recommend that very often, especially for older, because it's not socially, it's not very comfortable.
So sounds like it's probably a good idea for parents of kids in the growing age, especially infants, younger children, to at least do a BLS. I know all the physicians, healthcare providers are required to do BLS and ACLS, but probably it's not a bad idea for all parents to do a BLS course. You can pay and get it done at any of the healthcare facilities. My wife did one herself, and I think this is something if you, especially if you have kids with medical issues, seizures can be a part of it. But in any other situation, if they can get into trouble, kids can swallow anything. You may need a Heimlich to get that stuff out, or God forbid, they need CPR or something like that. You can save your kid's life. So it's definitely worth your time and money
Of
to do a
course.
BLS course for $100 and learn the basics of saving life. You may save your own kids' lives, or maybe lives of people around you. All right. So jumping on to the subject of epilepsy. So first, tell us the difference between seizure and epilepsy. A lot of people use it interchangeably. Oh, he has epilepsy, he has a seizure. We think pretty much in the same terms. But is there a difference between seizures and epilepsy? When do you call it a seizure? When do you call it an epilepsy? Because
Yeah.
you're an epilepsy specialist, so now we are kind of getting into your wheelhouse.
Okay. Yes, they are different. They kind of, it's the same thing, but the difference is that, for example, if you have a single isolated event and it's like a proper seizure, or which could be generalized tonic-clonic seizure, or it could be the stirring episodes or whatever type of seizure. So if it's a single episode, we call it like a seizure, like a single seizure. Even if there are two seizures within the same day, within
Mhm.
24 hours, we still call it seizure. We don't call it epilepsy.
I see.
So the term or the label of epilepsy comes if you have or someone has two or more seizures more than 24-hour apart.
I
Only
see.
then, and they have to be non-provoked. So here's the question. The question is that, can a normal brain have a seizure? Answer is yes. A normal brain can have a seizure in situations of, for example, fever, in situations of electrolyte imbalance. If you have like low calcium level, sodium level very low, or magnesium level very low, you can have a seizure. In case of trauma, like, you can have seizure. In case of low blood glucose, in our the people who have diabetes, they
Yeah.
can get seizure just because of the low blood glucose, but that doesn't mean they have epilepsy.
So epilepsy would be when you keep having seizures without any obvious reversible causes. Is that
Correct.
right?
Yes.
Okay, wonderful. How common is it in kids, especially epilepsy as part of your neurology practice? How common is epilepsy as a problem? What's the prevalence? Is it something really common? Is it uncommon? Hard to find?
It's very common. It's just like around like 1 to 2% of kids have epilepsy. And
Uh,
I'm a like pediatric neurologist. My specialty is epilepsy. But when I do clinic, I also do some kind of some general neurology. So
mhm.
what in my practice, 50 like 60% patients are epilepsy. And
Mm.
rest are we get headaches, tics, or other neurological disorders. It's
So,
that common.
so of all the neurologic problems that you see, epilepsy is probably about more than half patients.
Correct, especially in pediatric population. Adult is different. They have so much different kind of pathology.
Wow. So, what causes epilepsy in children? Is it all genetic? Is it all environmental? Is it a combination of genetic and environmental factors? What is the reason that kids get epilepsy?
And the answer is all of the above.
All of the above.
Yeah, many factors play a role. Obviously, genetics play a role. And if there are certain genes which run in the family, for example, febrile seizure, so they typically run in families. And then there are certain seizures we call like juvenile myoclonic seizures, they run in families. And then there are certain genes which causes like epilepsy in families. And I want to tell you one more thing. For epilepsy, so we will talk like one by one. So let's talk about genetics first. Genetics, as we also discussed in our previous programs, that we human beings basically are a script, and a script is written on DNA, and
Mm,
then we walk on that script when we with age. So if there is a like a genetic thing, so it will trigger at when you reach a specific age.
mm,
It will just become active. And I want to tell you one thing. If we say that like the epilepsy is genetic, but it does not mean it always comes from parents. Many of the genetic epilepsies are actually de novo mutations which happen at some point, either during pregnancy or after the pregnancy. So it's not always that if like they will come from parents. And then the other factors. So basically, another thing we need to understand about seizures or epilepsy. Seizure itself is it's just like a fever. It's not a. It is just a response of a brain that there is something wrong with me,
mm,
and that a brain actually registers its complaint in the form of a protest, which appears in the form of a seizure. The epilepsy can happen if during so the most critical period is the period around the birth. If at the time of delivery there is a hypoxic damage, if during the time of the delivery baby does not get the hypoxic damage mean baby does not get enough oxygen,
yeah.
if some trauma happens. So
Mm,
when babies are very very little or they are born premature, the blood vessels in the brain are very fragile and they tend to rupture. They may cause bleed inside the brain, or they may also cause what we call ischemic type of strokes. So they can happen. And then some kind of trauma to the brain, it can cause like epilepsy. Or there could be something which is like infection during pregnancy, because they can also cause scarring in the brain, and then seizures can happen. Or sometimes your brain is not formed accurately. You
mm,
know that if you look at the brain, it makes of so many conversions, sulci and gyri.
mm,
So in even one teeny tiny piece of sulci and gyri, it can be abnormally formed. So that can also cause epilepsy. Sometimes a very severe type of trauma that can also cause epilepsy. Or then there are factors, for example, when your brain cannot metabolize certain vitamins, which could
mm,
be like the folate. If it cannot metabolize, so it can cause epilepsy. The vitamin B6, pyridoxine,
mm.
that can also cause. Or some kids
Like the
cannot
deficiency of B6?
deficiency of B6, correct. There is a type of epilepsy which gets responsive to when you give vitamin B6, it gets better.
Mm,
And then the biotin is another cofactor which can cause epilepsy. Then one of the conditions is we call glucose transporter issue. For example, your brain cannot use glucose. So in that situation, the kids develop epilepsy.
oh,
And plus these are the stuff which we so far understand, but
yeah.
then there is literally one third of the category which we do not understand why the child is having epilepsy.
That's pretty comprehensive. So let me ask you specifically, because especially during this government, there has been a lot of debate about vaccine induced harm. If vaccines are increasing the risk of autism or some other genetic problems. And of course, vaccines save lives and we will all get our kids vaccinated. We're not going to stop doing that. But of course, when kids have seizures, parents are always looking for something to blame or something to eradicate from their life or something to find that could have triggered this whole thing. And once in a while, the timing with the vaccine kind of, matches the timing of the seizure. In your research, have you find any kind of association of seizures or epilepsy with any kind of vaccination?
So normally vaccines do not cause epilepsy at all. So that's for sure. They are protective. They protect you. One of the things which vaccines do, they protect you from like one of the like severe form of infection which can cause, for example, meningococcus.
Hmm.
So that bacteria literally destroys the brain.
Yeah.
And then but there is a there is one situation when the vaccines do cause seizure, and we call like vaccine induced seizure. But when you investigate those kids, basically they have an abnormal sodium channel. And I this is basically, it's not the vaccine which will it just becomes a coincidence that when you give the vaccine and they, because after vaccines definitely your body reacts and then the seizure happens, but usually there is a underlying genetic issue.
I see. So correlation does not mean causation. That's a
Correct.
old adage that we learn in medical school. Tell me about, because you mentioned trauma as a reason for seizures, and kids these days love playing sports, and the highest paying sports are the ones that are contact sports. But have you noticed any kind of association with particular sports and increased risk of brain injuries or eventually seizures or epilepsy? Any kind of sports that you won't let your own kids play because you're so worried that they may get problems?
Actually, there is no specific sports which gonna give epilepsy, and the normal traumas usually do not cause anything. Like normal injuries are okay. Maximum you may get a concussion, but
Hmm.
or you may get migraine for some time, headache
Mm,
for a little bit. But epilepsy does not happen. Epilepsy will occur if the injury is severe enough.
mm,
But usually we, for example, trauma-induced epilepsies, which we normally see in case of motor vehicle accidents,
I
like
see.
when it's just a car is like driving at the speed of 50 miles per hour, 70 miles per hour, and then you get injury. So
I
whenever
see.
your brain gets involved,
Mm,
so then epilepsy can happen.
I see. So American football is not contraindicated in kids who are
Just wear a
epilepsy.
helmet and wear a protective gear.
Protect yourself.
Follow
Yeah.
the rules which your coach like.
All right. That makes sense. Yeah, that's fair. Are there any other lifestyle factors or triggers that make seizures more likely in kids in today's day and age?
Okay, so let me tell you. So lifestyle does not is not a cause of epilepsy. First of all,
Mm,
if somebody say that he's somebody sleeps late and that's why he has epilepsy, or somebody ate certain food and it's epilepsy, no, that's not the thing. But
mm,
if you have epilepsy, then lifestyle is very important for you. Because for example, if you sleep late, or you are not regular in sleep, or you there is no pattern to your sleep, so then epilepsy definitely gets triggered and seizure can happen. If you are not consistent with your nutritions, you get like dehydration, then epilepsy can happen, like seizure can happen. Another lifestyle, like playing video games, especially in a dark room with lots of strobe lights, that can trigger seizure. Or not taking care of your health in general, that will trigger seizures. And plus the other thing, so among the lifestyles, normally sugars are not very good for epilepsy. We even have one of the treatments of we treat epilepsy even with diet sometimes, and we call it ketogenic diet. So
mm.
basically we avoid sugars in that diet,
I see.
and the
I see.
people get better.
So when a kid presents to you and the concern is for seizure, what does the workup for diagnosis look like? What are some of the initial tests that you would do? Because you mentioned a lot of things that we normally don't see getting tested. For example, the B6 deficiency or some of the other channel transporters that you mentioned that could be triggering the seizure. So normally what we would see, and I'm not a pediatrician, but I've seen kids getting worked up for seizures, and usually the workup includes MRI and maybe some basic metabolic panel and an EEG, and usually the buck stops there. Sometimes you would get a 24-hour EEG monitoring or something like that. But what's a comprehensive workup for epilepsy look like that should be done on pretty much everyone who is being worked up for epilepsy?
Okay, so let me walk you through this path. So a patient comes to you. The very first thing is, and most important thing, is history. And we know that history resolves mystery, and it will. So that part is very important. So get a very good history in a chronological order. Find out what's going on, anything in the family, any allergies, what happened at birth. Understand your patient well, and then keep in mind that seizure can happen even in a normal person. So look at all the labs, all the factors which can cause seizures. So the proper baseline labs are very important. And then for us epileptologists, there is a test which is very important and we love it. It's called electroencephalogram, or EEG. And this is a test in which we put a little bit like small metallic plates on the scalp, and we basically attach it with a gel or a special type of glue. And then these metallic plates act like a satellite, and they, whatever electromagnetic communication happening in the brain, they pick that. And on our screen, we can
Mm,
see these, the communication of the brain appears in the form of waves we call brain waves, and they appear like a little bit of chaotic. So we are trained to look at those waves, and these waves look very different from EKG. So in
mhm.
EKG there is a rhythm to it,
Yeah.
like QRS, PQRST,
There's
like,
a pattern. Yeah.
but there is no pattern. It looks very chaotic, the
Mm,
brain waves of EEG. But that chaos in a normal brain is good. Okay. So we are basically specialized in interpreting those waves.
mm,
So we can look at when, if the waves get slow somewhere, or if these waves get a very specific kind of discharges. We call them spikes or short waves, which are of many different types. Or sometime it starts showing a very specific pattern, and those are the seizures. So based on that EEG information, we find out what type of epilepsy is this. Even we decide about which medication are we going to use
mm,
based on the information which we get from the EEG. Okay, so that is the one, that's the one test. And one of the fundamental thing, even for a general population, what we really need to understand from EEG, whether it's the epilepsy which comes from all over the brain, we call it generalized epilepsy,
mm,
or this is the epilepsy which is coming from a very specific spot in the brain, we call it focal epilepsy, because
mhm.
the treatment for are basically both are different. Okay, the third test is called MRI, and it is a test in which we put you in a magnetic machine. It's like a magnetic capsule, so you go into that capsule and we get information, like it gives the image of the brain. So we look at it thoroughly to find if there is something wrong in the brain. Then the other test which we normally do, especially in pediatric population, we do it these days, we are doing quite often, looking at into the genes, study the genes, if
Yeah.
there is anything wrong in the genetic makeup. So we look at that, because that also helps us with treatment. So these are the basic tests.
I see.
But if you, depending, and majority of the people, like they get better, just they get like the answers just with these tests. But in situations when seizures do not get better, or we find a some clue in the brain that, or in the images, or in these tests, that person is a surgical candidate,
Mm,
then we offer other different tests.
I
So,
see.
which can be the nuclear scan, we call it PET scan, which could be the magnetoencephalogram, it's called
Mm,
MEG. Or we can also use like other tests in which we put a magnet, like a nuclear substance into your brain while you're having a seizure.
I see.
Yeah, it's called SPECT scan. And then the surgical techniques are a little bit different. We may come later on.
Okay, now talking about the EEG, because the question always is how long do you need to monitor the kid with an EEG to diagnose or rule out a specific type of seizure? Do you need to monitor them for an hour, for 24 hours, for a week? So, how do you decide how long you want to monitor someone before you let them go home or before you say, okay, this is enough and you do or do not have what I was thinking?
Very important question. So the answer to this, it varies from patient to patient. There are some patients, even I would say even 20 to 25 minutes of EG is enough. You do it and you get your finding and you're done. Case is over.
Mhm.
And sometimes even you may even not need to do MRI, because it becomes so obvious that this is the type of epilepsy you have. But when you do not find the answer, then there is a need to get more data.
I see.
And it also depends how frequently somebody is having a seizure.
Mhm.
If, for example, someone is having a seizure once in a week,
Mhm.
so in those situations we will have to basically keep you in the hospital for the whole week, and then we
Wait for the
look at
seizure.
the episode.
Yeah. Yeah. So, do you need to see an epileptologist if you are worried about a seizure? Because most people don't have access to an epileptologist. So just seeing a pediatric neurologist, because you did pediatric neurology and then you got 2 years of specialized training to diagnose and treat epilepsy and seizures. Is it enough to see a pediatric neurologist and just trust their judgment, follow their recommendations, or everyone who is worried about their kid having a seizure or worried about recurrent seizures or epilepsy needs to be seen by an epileptologist at least once to make sure that nothing serious is being missed, like a genetic disorder or some kind of unusual deficiencies?
I would definitely go to an epilepsy doctor. For example, if you do not have, if you live in an area where pediatric epilepsy specialist is not available, then you may do a regular follow up with your local pediatric neurologist. But then, if the pediatric epilepsy doctor is available to you, maybe 4 hour drive or 3 hour
Mm,
drives, I would do that maybe once in a 6 month, and then I would build a strong communication between epilepsy doctor, epileptologist with the pediatric neurologist, so
mm,
that you can get the care, like local care from your pediatric neurologist,
yeah.
because it's
Uh,
a specialized training and it needs like a special fellowship.
yeah.
So there
Yeah.
is a chance that like our general pediatric neurologist, they may miss some stuff.
They may miss something's important.
Mhm.
And one more question on that subject of things that can cause seizures or epilepsy. Now that there's more awareness about sleep apnea, and a lot of people think if you're not getting enough oxygen to the brain during the sleep or you're not getting enough sleep, that could be triggering the seizures. Is a sleep study part of the regular workup for seizures or epilepsy, or is not something you normally recommend?
Okay, so I want to. So not everything which look like a seizure is a seizure. So there is something called parasomnias. So there
Mm,
are many conditions which are basically sleep disorders. For example, night terrors. The child would wake up in the middle of the night, start screaming. Yes, it can be a seizure too. There are some seizures which appear like that, especially frontal lobe seizures, in which there is a very like aggressive type of body movements. But there could be, it could be just sleep issue, or if the child moves a lot at night, it could be like a restless leg syndrome, or it could be REM sleep disorders. There is a sometimes there is a need of sleep study.
yeah. So we don't have time, and I know it's another subject of in its own, and we probably will need another hour of yours to discuss all the medications that are being used these days to treat seizures, their effects, their side effects, when to use them, when not to use them. And that's probably something that's going to be helpful for more than the patients and their families. It's probably going to be helpful to the pediatric neurologists and the students and residents in training to learn about these medications and see what are the options available. But generally speaking, how has the treatment of epilepsy evolved over the last 10, 15 years that you've been practicing, and how successful you are in treating epilepsy or curing it to the point where kids can live a very normal and functional life? Because sometimes when you talk to the parents, especially in third world countries, usually the answer is, I don't want the workup or I don't want to do more investigation, because even if they diagnose it, either the kid will have to take a medicine for the rest of their life and they will still keep having seizures, and they're not very optimistic about the chances of success. As a pediatric epileptologist, what's your advice to parents with kids who have epilepsy? Is there hope? Are the medications good enough? And how successful is the treatment?
I would just say one thing: please do not give up on
Mm,
your children, on your child. So there is a lot of advancement, especially last 10 years were amazing. And I have, like, even in my practice, there are living examples when there are certain parents, and I really admire them because, and they did not give up on child, and now their child is are there. There were times when they were having 200 seizures per day,
wow.
to a time now they are honor students and they're living a normal life. For example, there are some parents who the kids who even got like infantile spasms,
Mm,
and then normally if you get the infantile spasm, it means it's a permanent lifetime disability. You will get, eventually you will get something like epileptic encephalopathy, and we call Lennox-Gastaut syndrome. But there were parents who did not give up, and the
mm,
child is having a normal life.
yeah.
So it's literally a team effort, and parents willpower, your child's willpower, and your doctors, like everybody has a very important role in it. And
Mm,
the few advances which has happened, especially in the last 10 years, especially there is a lot of work has been done in genetics. 10 years ago, when I was in training and even during my residency time, we were hardly doing genetic testing. But
Mm,
now somehow the genetic testing have become so available, readily available, and I pretty much do on every other child. So there were even some genetic program companies which were offering genetic testing for free. So
mm,
that was an amazing thing. So what has that done? Because now there is an emergence of a new thing in epilepsy, which we call precision medicine.
mm,
Precision medicine means if we find out like seizure happening due to a very specific gene,
mm.
so this very specific gene has a very specific medication, and you get better.
Wow.
I remember for example, there was a KCNT1, like there was one of the mutations. And I have heard from my mentor, Dr. Lillian Wiley, that quinidine, which is an anti-malarial medication,
Yeah. Yeah.
works for that, can work on this. So I, after failing all medications, I just thought, oh, Dr. Wiley said this thing, and I started anti-malarial medication. Patient got better. So that
Wow.
was like one of the example of precision medicine. And then the other advancements, especially in the advancements of in imaging, that
Mm,
has played a very important role. Like for example, like surgery is one of the ways of curing epilepsy, and the curing mean if you find out where the epilepsy is coming from, if there is a lesion in the brain, so that's a, if you can take that lesion out, normally you can get seizure free. And better MRI techniques, better training in neuroimaging. If you have a like a very trained eye who can pinpoint and spot abnormality in the brain among
mm.
radiologists, because we work together.
Yeah.
Then like especially the softwares which modify images. For example, there is something called, we have a regular PET scan. There is a technique called quantitative PET scan. So they just flip flop the images of a
Mm.
PET scan, just like an X-ray, like a
Yeah.
negative,
Yeah.
and it you get like abnormality out of it. So
Wow.
many a times we even when I was a fellow, there was a time when I was ready to present for a surgical exploration of the child, and immediately we had the quantitative PET result came back. It came and we said no need for invasive study, just do the surgery right away. And
Wow.
surgery was done and patient was seizure free. For example, there is another technique called voxel based morphometry, VBM. You can, it is just like a regular MRI, and the software with the application of softwares, you can see so many other things. And the other thing, the AI, for example, it is playing a big role. It has made our life pretty easy because these epilepsy, these files are so long. So I'm like imagining like reading a 7 day of EEG.
Yeah. So now
It is
you're letting AI
exhausting.
take.
Yeah, but now with the help of AI, at least it, we don't 100% rely on it, but at least it gives you some kind of help, like in spike detection or sometime the seizure pattern detection. So,
It can focus on those areas that could have been missed otherwise, and then you can see if it's something real or not.
and the last thing, the newer medications are amazing. Some of
Mm.
them are so good.
I see. So I don't want you to name any medications yet if you have time, because I don't want people to hear the names and then start buying stuff, because we have a lot of audience from
Mhm.
Pakistan as well. And sometimes they hear about a medicine and they kind of harp onto it and they don't try to delineate whether it is something right or wrong for them. So I don't want you to name medicines yet. If we talk about medicines, we'll talk about them in details with all the pros and cons and different side effects. But
Mhm.
generally speaking, how many people have controlled seizures on a single pill versus requiring two pills or three pills? And how long does it take for you to get the seizures under control? The reason I ask this is, especially in our family back home in Pakistan, they would see one doctor and start one treatment. And if they don't get better within a week, they would go to a different doctor, maybe a third doctor, maybe a quack, maybe a homeopath, maybe a Rouhani alim like Baba who will give them a wazifa, which is perfectly fine. But just the importance of sticking to your physicians and following up a plan. If one thing is not working, you switch to the other. In your experience, how does the treatment, stepwise approach to the treatment look like when you are dealing with kids with epilepsy?
In general, like when you give first medication, there is a 46% or 50% chance that this medicine will work.
I see.
So then you need to have another medication. So when there is a need for second medication, and the we call the failure of the first medication after you have reached to the
like the full recommended dose. It's
Mm.
not like you gave the lowest quantity of medication and then it didn't work and you saw it's failure. That's not the failure. It's
Mhm.
like you have to fine tune the dose.
I
So
see.
if that has failed, then you add the second anti-seizure medication. The second anti-seizure medicine will take a control of 34% more people.
I see.
Okay. So then there is a role of third anti-seizure medicine. The third anti-seizure medicine usually just adds 4% value, which means that this is the time your child has a drug resistant epilepsy.
Mm.
And maybe this is the time that we have to think something more than medication.
I see.
Something more than medication could be diet. We call it ketogenic diet. It could be like some kind of device which we can put in your body or which can control seizures. Or it could be something, or it could be like one of the surgical options.
And the devices you put in the body, they just to name them, is it like a vagus nerve stimulator or a deep brain stimulator, or what are they called? What are those
Yeah, so
devices
I even
called?
have a vagal nerve stimulator sitting in front of me right
Oh,
now.
you do?
It's a very small device, and which you can, with your either vascular surgeon or neurosurgeon, can put in your into the body. So what it can do is they can create a very small pocket in the chest,
Mm.
and then this is the lead. This is the vagus nerve. This is the actual like vagus nerve lead, and
Mm.
this section goes into the vagus nerve, and then the vagus nerves. This part gets wrapped around the vagus nerve, and this keeps on giving electrical impulses to the brain, and then over time it reduces the epilepsy burden. And another
Mm.
thing, for example, this is also one of the ways where you can even deal like a seizure. For example, this is one of the rescue medicine. For example, we give parents a magnet, so they can just swipe the magnet
Mm.
on it, it gets triggered, and then it stops the seizure. And
Wow.
this is not a medication, so this is a non-medical option. The other
Wow.
thing which we have available right now is called responsive neurostimulation. This is
Mm.
like the devices. So when we find out there where the seizure is coming from, so we can just put this device into the skull. It gets, and then the lead go from this device all the way into the area where the seizure come from, just a cardiac defibrillator. So you just give a
Wow.
little bit of current and you stops the ectopic focus.
Wow.
Similarly, this device works on the same principle. If
Mm.
in a certain region you get the seizure, so this
Mm.
device will give a stimulation which is way faster than the seizure, and it will stop the seizure. It will
Wow.
just give a shut up call to the seizure, and the seizure will say, "Okay,
It's
fine."
an actual device, not your keychain that you are showing us, huh?
Yeah, this is a I'm so sorry. Yeah, there is no keychain in the actual one.
Okay, but it is an actual device that stops
Yeah,
the seizure.
yeah.
And when you were showing the vagus nerve stimulator and you started saying you can get it from, I thought you were gonna say you can get it from any Walmart or Kroger and
So
get
yeah,
it
usually
implanted.
they're not available in Kroger, Walmart, but your doctor would know. They would have access
Wow.
to these companies, people from these companies who
Yeah.
will help you.
Yeah. So these are some of the things that can be used if the medications fail or in addition to the
If
medication.
you have to fail two anti-seizure medications.
I
And
see.
another thing, like there is a change in the terminology of the medication.
Mm.
Previously, we used to call them anti-epilepsy medicines. But since these medicines, they do not eradicate epilepsy, they just control epilepsy. So that's why we have changed the name. Now we call them anti-seizure medicines.
I see. I see. We remember from anatomy classes that vagus nerve slows down everything, right? Slows down your heart, slows down your gut and other parts of your body too. So, does it really slow down everything when you are stimulating the vagus nerve to reduce the seizures? So, what are the side effects that the kids notice once you activate it?
Very good question. So actually, so what they do, so normally like by shifting the cathode and anode,
Mm,
so the current only goes from your neck upward.
I see.
It does not go your neck downward. So
Wow.
probably you were worried that it would cause bradycardia and then it will also
Yeah.
affect the guts. No, but that's not the case.
Well,
So there is
that's
a blockage here electronically. So you it just unidirectional flow.
well, that's very smart. And you mentioned some of the surgical interventions. Does the surgery still look pretty ugly where you have to open the whole skull and expose the brain and put something in there? Or has there been any advances in the surgical techniques that has made it a little bit less invasive and less traumatic for the kids?
A very important question. So now the epilepsy surgery is totally changed.
Mm,
So there was the back in like 80s, 90s, and early 2000s, there was the way we were doing epilepsy surgery in which we had to open the
mm,
skull bone, and then we had to put a grid on the surface of the brain, and then we would try to get better quality EEG directly from the brain surface, and then we would do cortical mapping and find out where the seizure is coming from. And we wanted to save the precious part of the brain. We call it eloquent cortex because not at any cost we can damage that part. So that method is pretty much changed now. So now we have a very special type of method in which we use electrodes, which literally looks like a needle
mm,
electrodes, which are 6 to 10 inches, and then they can be administered just by a simple burr hole into the skull,
mm,
and then we put these electrodes all the way into the brain, and these they even deep into the sulci and gyri, they give you information even from these regions, and even into the even into the deeper parts of the brain you get information. So then you map out where exactly they are, and basically the other change has happened because there is a change in the concept of epilepsy. Now,
mm,
previously we used to believe that epilepsy just come from a very specific area. But now the modern belief is that it's basically a network. It's the full network which you aim at, and it comes from somewhere from that network. You target all those areas using those very special needle electrodes, and then we capture like seizures, and then we identify where they are coming from.
I see. That's very fascinating. So a lot of hope for kids with seizures and epilepsy, especially if you can get to the right people at the right time. One last question, because we had to pause our podcast and you got one of the pages from the emergency room, a kid who had a possible seizure, had a breath holding spell. And tell us a little bit about it, because once in a while the kids, when they're throwing tantrums, they would hold their breaths or they would just stiffen up and their whole body becomes a little bit tight. How do you differentiate that from something like a seizure versus just kids being kids and throwing a tantrum and just being a nasty kid at that moment?
Okay, so very good question. So it is very important to basically identify like whatever symptoms your child is exhibiting, is it really a seizure or not a seizure? And it
Mm,
is, for us it is very easy, not very difficult to differentiate whether something is truly a seizure or it is just something. So Ahmed asked like a scenario when some kids, they cry, and when they cry all of a sudden they held their breath,
yeah.
their body turns blue
Mm,
or it becomes pale,
yeah.
and then sometime even they start like body twitching during this, and it look very frightening.
Yeah.
So is it epilepsy? So these very specific thing is something we call breath holding spells,
Mm,
and these are, by doing EEG test, we can determine very easily that, and whenever these episodes happen and we do not see any change in the brain, so they are not epilepsy. Many times these are due to iron deficiency, and
yeah.
you do the iron studies, and if iron studies are normal you fix the iron and these episodes get better. Similarly, there is a condition like called benign myoclonus of sleep. There are kids
Mm,
during sleep they start like the twitching of one part of the limb, and parents freak out, oh, this is, it could be like look like a seizure. So we can do EEG and during their when they sleep, and then when we capture these movements, there is nothing, there is no seizure. The
mm,
other very common scenario in which the kids, they become like the sudden stiffness of the legs.
mm,
When we do EEG, we do not see anything in the any change in the EEG. So these episodes are called paroxysmal dyskinesias. Basically, your muscles stiffens up. The treatment is totally different. For example, there are certain situations when you have a child has a headache, a
mm,
migraine, and then after that there is a paralysis on one side of the body.
yeah.
That is not a, because there are certain seizures in which after the seizures your brain get exhausted, all the neurotransmitters are consumed, and you get sort of like a transient paralysis of one side of the body, we call it starts paralysis. But that similar situation can also happen in case of migraine. So the bottom line is getting the right test and getting to the bottom of the situation. Like, it's very important to know, is it truly an epilepsy or something else going on.
Perfect. Dr. Mahfouz, that was very educational and very helpful. And I have a lot of questions for you, but I know you have to go. We will have one more session for our audience who are interested in learning more about the subject. We'll have one more session with Dr. Mahfouz where we are going to just discuss all the medication treatment options for kids with epilepsy. He has a wealth of knowledge and he's been very kind and generous with us, sharing that knowledge and giving us his precious time. So we are very grateful. Our audience appreciated the last podcast that we did together and they learned a lot and we got a lot of messages from the audience. And I'm sure after listening to this episode, we are going to get a lot of messages. And actually, I may have to share your email address with some of the parents who have concerns about their kids, especially the parents who don't have access to an epileptologist, friends and family from Pakistan, and some of the audience who want to learn more about their kids' development as well as their growth and progress. Really appreciate your time. Really appreciate all the effort you put into today's podcast. If there's anything else you would like to say before we say goodbye, please go ahead and share it with us. Any parting words of advice, words of wisdom?
So my last piece of advice. So the most important asset in diagnosing epilepsy is your observation.
Mm,
So if as a parent you're observing and you are noticing that something not right with my baby, these days every single of all of us have cell phones with cameras. So just make a video of it.
mm,
And that video sometimes can be more helpful than even EEG or MRI, because there is also a part of we will some if, at some point we will also have a very specific session on this thing, which we call the how seizures are seen clinically. So
mhm.
it's like semiology, so that you can do like from your cell phone.
Yeah, yeah. I think on the same note, now these days people have webcams all over the house to protect the house. I would say, parents who have kids with any kind of medical problems, but even without any medical problems, it's never a bad idea, especially if they're, younger than the age where they need their privacy, they're not in their teens and they want their own private time. It's always a good idea to maybe have a camera in their room or in the living area where they normally play. So God forbid something happens, it captures it and you can share it with the doctors and show it to them, so make it easier for them to diagnose them and treat them sooner rather than later. Thank you very much, Dr. Mahfouz. Thank you to everyone who's going to be listening to this podcast. Please share your comments, please share your suggestions regarding these podcasts, share any subjects that you want us to discuss in the future. Our next couple of podcasts are going to be related to kidney disease, which is very close to my heart. We're going to talk about the living kidney donation, who should be donating a kidney, who should not be donating a kidney, who should you be donating to, what are the pros and cons of doing that, as well as a specific kidney problem known as IgA nephropathy, which is getting more attention because of all the new developments and the new treatments that are out in the market. So stay tuned, cite and prescribe our channel for future recommendations, and we will see you in the next podcast. Until then, love is, take care, goodbye.